Donc, hello everyone, bonjour à tous. Thank you for participating in today's technical briefing, which will provide an update on the COVID-19 vaccine extended dose intervals in Canada. Bienvenue au briefing technique pour donner une mise à jour sur les intervalles prolongés des doses de vaccins contre la COVID-19. Today, we will hear remarks from the Chair and the Vice Chair of the National Advisory Committee on Immunization, Drs. Caroline Quash and Shelley Deeks. We will also hear from Canada's Council of Chief Medical Officers of Health, represented today by Dr. Bonnie Henry from British Columbia, as well as Dr. Jennifer Russell from New Brunswick. Finally, Dr. Howard New, as well as Matthew Tunnis from the Public Health Agency of Canada, will be available to answer questions during the Q&A session. Donc aujourd'hui, nous entendons des allocutions des Drs. Caroline Quash et Shelley Deeks du Comité consultatif national sur l'immunisation. Nous entendrons également le Conseil des médecins hygiénistes en chef du Canada, représenté aujourd'hui par la Dr. Bonnie Henry de la Colombie-Britannique, ainsi que la Dr. Jennifer Russell du Nouveau-Brunswick. Enfin, le Dr. Howard New ainsi que Matthew Tunnis de l'Agence de la santé publique du Canada seront disponibles pour répondre aux questions lors de la séance de questions et réponses. If you wish to ask questions, please press star 1 on your phone. Si vous désirez poser une question, veuillez appuyer sur étoile 1. Note that the content of today's briefing is for attribution. Le contenu de la session d'aujourd'hui est pour attribution. Procédons à la séance d'information technique. Let's begin today's technical briefing. Over to you.
Okay, good morning, everybody. Dr. Quash Tan and I would like to share with you today that the National Advisory Committee on Immunization, or NACI, released a full statement on its extended dose interval recommendation. The substance of the recommendation has not changed. However, the statement provides detailed evidence summaries and complete analyses that support the recommendation to extend the time between the first and second dose of COVID-19 vaccines for up to 4 months. Second doses should be offered as soon as possible after all eligible populations have been offered first doses, with priority given to those at highest risk of severe illness and death from COVID-19 disease. With Canada's expected vaccine supply, the interval between the first and second dose is expected to be less than 4 months. Extending COVID-19 vaccine dose intervals will optimize early vaccine rollout and population protection, and will enable more Canadians to receive their first dose more quickly. It will allow faster population level protection, offering protection to the individual in 3 ways: from their own vaccination, by vaccinating those around them, and possibly by decreasing spread of the virus in the community. NACI has also emphasized that jurisdictions, when determining the vaccine policy within provinces and territories, may choose to shorten the interval between the first and second dose in specific populations based on local epidemiology, local vaccine supply, public health considerations, and emerging data. In making our population-based recommendations, we carefully considered all available evidence. We looked at clinical trial evidence that demonstrates very good vaccine efficacy from the first dose. We also looked at new real-world evidence that suggests good vaccine effectiveness against symptomatic disease and asymptomatic infection, and very good effectiveness against hospitalization, including among older populations after the receipt of the first dose. We also looked at mathematical modeling, which demonstrates that accelerating vaccine coverage by extending dose intervals would have substantial population benefits by reducing symptomatic disease, hospitalizations, and death, while there is limited vaccine supply. We considered principles of vaccine science and immunology, which show that a longer interval between the first and second dose generally results in better immune response after the second dose. And experience with other multi-dose vaccines, which suggests that protection from the first dose of the vaccine series can last 6 months or longer, while second dose extend protection for even longer. And finally, we looked at the public health principles of ethical decision-making, including equity, feasibility, and accessibility, which favors extending intervals, especially while COVID-19 cases, severe disease, hospitalizations, and deaths are high. And in addition, faster progress towards population protection will help to protect vulnerable populations. NACI's expert opinion was also considered that within a global pandemic setting, reducing the risk of severe disease outcomes in the majority of the population and decreasing transmission in the community will have the greatest public health impact. More information will become available as vaccination programs continue to roll out in Canada and around the world. NACI will continue to closely monitor the evolving evidence on the effectiveness of an extended dose interval and will update our recommendations as needed. Thank you.
You're on mute, Caroline.
Et moi qui pensais avoir maîtrisé Zoom. Désolée. Donc, je poursuis en français. Donc, Dr. Dix et moi aimerions vous informer qu'aujourd'hui, le Comité consultatif national de l'immunisation a publié la version intégrale de sa déclaration sur sa recommandation pour la prolongation d'un intervalle entre l'administration des doses de vaccins. La nature de la recommandation n'a pas changé, mais la déclaration résume les données probantes et l'analyse complète qui appuie la recommandation de prolonger jusqu'à 4 mois le délai entre la première et la deuxième dose des vaccins contre la COVID-19. Une deuxième dose devrait être offerte dès que possible, une fois que toutes les populations admissibles auront eu accès à une première dose, la priorité étant accordée aux personnes les plus à risque de maladies graves et de décès dus à la COVID-19. Compte tenu de l'approvisionnement prévu en vaccins au Canada, l'intervalle entre la première et la deuxième dose devrait être inférieur à 4 mois. L'allongement entre les doses du vaccin COVID-19 permettra d'optimiser le déploiement précoce du vaccin et la protection de la population et permettra à davantage de Canadiens de recevoir leur première dose plus rapidement. Ceci permettra une protection plus rapide au niveau de la population, offrant une protection individuelle de 3 façons. Premièrement, via notre propre vaccination. Deuxièmement, par la vaccination de notre entourage. Et troisièmement, éventuellement, en diminuant la propagation du virus dans la communauté. Le CCNI a également souligné que les provinces et les territoires, lorsqu'ils déterminent leur politique de vaccination, peuvent choisir de raccourcir l'intervalle posologique pour certaines populations en fonction de l'épidémiologie régionale, de l'approvisionnement en vaccins dans leur région, des considérations de santé publique et des données disponibles. En formulant ces recommandations dans un contexte populationnel, le CCNI a soigneusement examiné toutes les preuves disponibles, plus précisément les résultats d'essais cliniques qui démontrent une très bonne efficacité du vaccin dès la première dose, les nouvelles données d'utilisation suggérant une bonne efficacité de terrain du vaccin contre la maladie symptomatique et asymptomatique, ainsi qu'une très bonne efficacité de terrain ou réel contre l'hospitalisation, notamment chez les populations plus âgées. Les données ne démontrent pas actuellement une perte de protection au cours de la période suivie. Une modélisation mathématique qui démontre que l'accélération de la couverture vaccinale par la prolongation des intervalles posologiques aura des avantages substantiels pour la population en réduisant les maladies symptomatiques, les hospitalisations et les décès, alors que l'offre de vaccins demeure limitée. Les principes de la science des vaccins et de l'immunologie qui montrent qu'un intervalle posologique plus long entraîne généralement une meilleure réponse immunitaire après la deuxième dose. L'expérience acquise avec d'autres vaccins multidoses qui suggèrent que la protection conférée par la première dose d'une série de vaccins peut durer 6 mois ou plus et que la deuxième dose prolonge la protection davantage. Les principes de santé publique sur la prise de décision éthique, notamment l'équité, la faisabilité et l'accessibilité, lesquels favorisent la prolongation des intervalles, d'autant plus que les cas de COVID-19, les maladies graves, les hospitalisations et les décès sont élevés. En outre, des progrès plus rapides en matière de protection de la population contribueront à protéger les populations vulnérables. Finalement, l'avis des experts du CCNI, selon lequel, dans le contexte d'une pandémie mondiale, la diminution du risque de maladies graves pour une majorité de la population et la diminution de la transmission dans la communauté aura un plus grand impact sur la santé publique. L'efficacité des vaccins contre les variants sous surveillance rehaussée sera également surveillée de près, comme la prévalence de ces variants augmente au Canada. De nouvelles informations continueront à être disponibles au fur et à mesure que les programmes de vaccination se déploieront de par le monde. Le CCNI continuera à suivre de près l'évolution des preuves de l'efficacité d'un intervalle à dose prolongée et mettra à jour sa recommandation si nécessaire. Je passe maintenant la parole au Dr. Henry.
Thank you, and good morning. I'm Dr. Bonnie Henry, British Columbia's Provincial Health Officer, and I'm here with my colleague, Dr. Jennifer Russell, who's the Chief Medical Officer of Health in New Brunswick. And we are here today on behalf of the Council of Chief Medical Officers of Healthcare in Canada, which I am privileged right now to chair. I'm also very grateful to be speaking to you from the traditional territories of the Squamish, Musqueam, and Tsleil-Waututh First Nations here in Vancouver. The Council of Chief Medical Officers of Health, also affectionately referred to as CCMOH, provides direction and health advice and recommendations around effective public health practice across Canada, while each of us respecting the unique circumstances in our own province and territory. As part of the COVID-19 response, we are committed to implementing an approach to COVID-19 vaccination that brings the greatest benefit to all of our populations. The rapid development of safe and effective COVID-19 vaccines has provided an incredible and important opportunity to protect ourselves, our families, and our communities against COVID-19, particularly hospitalization and severe outcomes. We all want to return to a sense of normalcy, and it is vaccines that are our most important tool to helping us get this. The goal of our COVID-19 immunization response is to enable as many people as possible to be immunized as quickly as possible with safe and effective vaccines, while ensuring that those at highest risk are prioritized. This strategy will contribute to our overall pandemic response goals of minimizing serious illness and death at the same time as minimizing societal disruption. We are doing this by acting on evidence and public health principles and collaborating across all of our jurisdictions, as well as with our First Nations, Inuit, and Métis partners. With the increasing supply of the approved vaccines that are safe and effective against COVID-19, we are now well equipped to scale up vaccination and maximize protection of everybody in Canada faster. We are doing this first by vaccinating populations at highest risk of severe health outcomes and of COVID-19 exposure, and ensuring access to vaccines for adults in communities that have been disproportionately affected by COVID-19 because of social and economic inequities. As we accelerate vaccination across Canada, we continue to be guided by the expert advice of both provincial immunization committees and, importantly, NACI, the National Advisory Committee on Immunization. As Chief Medical Officers of Health, we welcome and support NACI's recommendation to extend the timing of the second dose of COVID-19 vaccine up to 4 months from after the first. Provinces and territories may be able to shorten this time, depending on their own specific population, based on their own epidemiology, vaccine supply, and vaccine delivery mechanisms. As we know, things are slightly different in each province, and particularly in our territories. Having as many eligible individuals as possible receive an effective first dose means that we can provide high level of protection to more people more quickly, saving lives and reducing illness. This critical first dose will lead to reduced transmission in the community and protect those who do not develop a strong response themselves individually. Once this is achieved, Specific populations will be prioritized to receive their second dose as soon as possible. We want to be clear that receiving a second vaccine dose as soon as supplies allow within that recommended interval is important and remains essential to achieving optimal protection from the 2-dose vaccines that we have available right now in Canada. The current and upcoming increases in vaccine supply, along with this extended dose interval, is going to support the rapid expansion and already has of vaccination across Canada. We are well positioned to have enough vaccines for everybody to have both doses by September, and we will continue to rigorously evaluate any vaccine safety signals relative to the risks that we see every day now from COVID-19, and we will take action as we need to following that evidence. We are learning more every day with the rapid pace of new science, but there is still a lot we do not yet know. If vaccinated individuals can carry and spread the virus to others without knowing it, how long vaccines protect us for, if current vaccines work against all of the variants of concern, and of course, we don't yet know when children can be effectively vaccinated. Evidence will continue to guide our approaches to protect all of those in Canada against COVID-19, and we will keep you informed as we learn. As we accelerate our vaccination in Canada, we understand that everyone is looking forward to returning to a sense of normalcy. We will be able to do this gradually based on our local and regional COVID-19 activity, based on the COVID-19 variants of concerns that are causing a rapid resurgence across much of Canada right now and threatening the sacrifices that we have all made to prevent and control COVID-19. We can't let our individual or our collective guards down until there is sufficient population protection from vaccination. This means that for now, we all need to continue with the public health measures that we know are effective, regardless of whether you have received 1 or 2 doses of vaccine or are not yet vaccinated. As Chief Medical Officers of Health, we are reviewing the evidence to inform when and how to safely adapt or relax these restrictive public health measures as vaccination rolls out. We will continue to work together across the country to provide clear and evidence-informed advice as the science and our situation evolves to keep everyone in Canada safe and healthy. Thank you, and I'll now turn it over to Dr. Russell.
Jennifer, you might be on mute.
Bonjour à tous et à toutes. Je suis le Dr. Jennifer Russell, médecin hygiéniste en chef du Nouveau-Brunswick. Je suis accompagnée par ma collègue Dr. Bonnie Henry, médecin hygiéniste provincial de la Colombie-Britannique. Nous sommes ici au nom du Conseil des médecins hygiénistes en chef du Canada. Le Conseil des médecins hygiénistes en chef offre une orientation des conseils et des recommandations pour faire progresser la pratique de la santé publique à l'échelle du Canada, tout en respectant les circonstances uniques des provinces et des territoires. Dans le cadre de la réponse à la COVID-19, les médecins hygiénistes en chef du Canada sont déterminés à mettre en œuvre une approche du Canada, une approche de vaccination qui offre le plus grand avantage à nos populations respectives. La mise au point de vaccins contre la COVID-19 nous a donné une nouvelle occasion de nous protéger individuellement ainsi que de protéger nos familles et nos collectivités contre les effets graves de la maladie. Nous voulons tous retrouver un sentiment de normalité et les vaccins nous aideront à y arriver. L'objectif de la campagne de vaccination du Canada contre le COVID-19 est de permettre au plus grand nombre possible de personnes d'être vaccinées le plus rapidement possible avec des vaccins sûrs et efficaces, tout en veillant à ce que les populations à risque élevé soient traitées en priorité. Cette stratégie contribuera à nos objectifs généraux de l'intervention contre la pandémie, soit de réduire au minimum le nombre de cas de maladies graves et de décès, tout en minimisant les perturbations sociales. Nous travaillons dans ce but en prenant des mesures fondées sur des données probantes et sur les principes de santé publique. Nous travaillons de concert avec l'ensemble des administrations ainsi qu'avec les partenaires des Premières Nations, des Inuits et de la nation métisse. Grâce à un approvisionnement accru en vaccins approuvés, sûrs et efficaces pour prévenir la COVID-19 symptomatique, nous sommes maintenant bien outillés pour accélérer la vaccination et pour maximiser plus rapidement la protection d'un plus grand nombre de personnes au Canada. Nous vaccinons d'abord les populations les plus susceptibles d'être exposées à la COVID-19 et d'en subir des séquelles sévères. Nous travaillons également pour assurer l'accès aux vaccins contre la COVID-19 pour des adultes qui font partie de communautés touchées de manière disproportionnée par la COVID-19 en raison d'inéquités sociales et économiques. Au fur et à mesure que la vaccination accélère à l'échelle du Canada, nous demeurons guidés par les avis d'experts des comités d'immunisation provinciaux et du Comité consultatif national de l'immunisation, CCNI. À titre de médecin hygiéniste en chef, nous remercions le CCNI et appuyons sa recommandation d'allonger l'intervalle entre les 2 doses de vaccin jusqu'à 4 mois. Les provinces et territoires pourraient choisir d'écourter le délai entre la première et la deuxième dose d'une série de 2 doses de vaccin contre la COVID-19 pour des populations particulières en fonction de l'épidémie locale, de l'approvisionnement en vaccins et des mécanismes de livraison en vaccins. Le fait d'avoir autant de personnes éligibles que possible qui reçoivent une première dose efficace signifie que nous pouvons fournir un niveau de protection élevé plus rapidement à un plus grand nombre de personnes, sauvant ainsi des vies et réduisant le nombre de cas de la maladie. Cette première dose critique entraînera une réduction de la transmission dans la communauté et protégerait ceux qui ne développent pas individuellement une réponse forte. Une fois que cela a été réalisé, des populations spécifiques peuvent être priorisées pour recevoir leur deuxième dose dès que possible. Nous voulons exprimer clairement qu'il demeure essentiel de recevoir une deuxième dose du vaccin dès que les approvisionnements le permettent, dans l'intervalle recommandé pour profiter de la protection optimale des vaccins à 2 doses. Les augmentations actuelles et prochaines de l'approvisionnement en vaccins ainsi que l'intervalle prolongé entre l'administration des doses appuieront l'entendu rapide de la vaccination à l'échelle du Canada. Nous sommes en bonne position pour avoir suffisamment de vaccins pour tout le monde d'ici le mois de septembre. Nous continuerons d'évaluer rigoureusement tout signal lié à l'innocuité des vaccins contre les risques liés à la COVID-19 que nous constatons tous les jours et nous prendrons des mesures décisives s'il y a lieu. Nous en apprenons un peu plus chaque jour, étant donné le rythme accéléré auquel les nouvelles données scientifiques sont présentées, mais nous ignorons encore beaucoup de choses. Les personnes vaccinées peuvent-elles être porteuses du virus et le transmettre à d'autres à leur insu? Pendant combien de temps les vaccins nous protègent-ils? Les vaccins mis au point sont-ils efficaces contre tous les variants qui suscitent des inquiétudes? Quand les enfants pourront-ils se faire vacciner? Les données probantes continueront de guider nos approches afin de protéger tous les individus au Canada contre la COVID-19 et nous vous tiendrons informés au fur et à mesure que nous en apprenons davantage. La vaccination s'accélère au Canada et nous sommes conscients du désir de tous de retrouver une certaine normalité. Nous pourrons le faire graduellement en fonction de l'activité de la COVID-19 aux échelles locales et régionales. Des variants inquiétants de la COVID-19 entraînent une résurgence rapide au Canada et mettent en péril les sacrifices que nous avons faits pour prévenir et pour contrôler la maladie. Nous ne pouvons pas baisser notre garde individuelle et collective jusqu'à qu'une proportion suffisante de la population soit protégée par la vaccination. C'est pourquoi, pour le moment, tous doivent continuer de mettre en application les mesures de santé publique que nous savons être efficaces. Ceci s'applique que vous ayez reçu 1 dose, 2 doses de vaccin ou si vous n'êtes pas encore vacciné. En tant que médecin hygiéniste en chef, Nous examinons les données probantes qui nous indiqueront quand et comment nous pourrons adapter ou assouplir les mesures de santé publique en toute sécurité dans le contexte de nos campagnes de vaccination. Nous poursuivrons notre collaboration afin de présenter des conseils clairs et fondés sur des données probantes au fur et à mesure que la science et la situation évoluent pour garder tous les individus au Canada en santé et en sécurité. Merci.
Thank you very much. We will now open the phone line to questions. Please identify yourself and include the media outlet that you are representing. We'll be taking questions in both official languages. We ask that you limit yourself to one question and one follow-up. Donc, veuillez vous nommer, nous dire quel média vous représentez. Nous vous demandons aussi de vous limiter à une question et seulement une question suivie. Vous pouvez poser vos questions dans l'une des deux langues officielles. Et nous aimerions vous rappeler que le briefing technique aujourd'hui est pour attribution. Donc, we'll start the question period. Operator, over to you.
Thank you. Merci. Please press star one at this time if you have a question. Veuillez appuyer sur étoile 1 maintenant si vous avez une question. Our first question is from Mia Robson from the Canadian Press. Please go ahead. À vous la parole.
Yes, good morning. My first question is about the news out of Europe today regarding the AstraZeneca vaccine, and they believe there is now a link to rare blood clots. Just wondering if this news will have any impact on NACI's recommendations in Canada, and if so, what?
Since Dr. New, maybe I could start off in terms of the process. Certainly, from the sort of the federal perspective, the regulator, Health Canada, is certainly aware of the situation in Europe, and I think the impending or the announcement by the European Medicines Agency. They've also participated in the meetings, and they're certainly aware of the evidence and what's been presented and what's coming forth from their European colleagues. And certainly, they're also getting information from AstraZeneca and also take the evidence into account what they're getting from the European colleagues. And so that'll determine their actions moving forward. And so with that, I'll turn it over to NACI in terms of what they would then do in turn after Health Canada. Thank you.
Thanks, Dr. New. So yes, as you're aware, NACI has already put out a statement to pause AstraZeneca use in those under 55 years of age. So we will await further information from our regulator, Health Canada, and we will continue to look at the situation and modify our recommendations if they need to be modified further. Thank you.
Thank you very much. Follow-up?
Yeah, and my second question is about the priorities that NACI listed, or the recommendations for priorities for vaccines. There are a lot of calls saying that essential workers who cannot work at home, even workers in factories and industrial workers, be prioritized even faster because there is a large spread of the virus in those groups. Is this something that NACI would support or would amend its recommendations on how fast that particular group should be vaccinated?
So I'm happy to take this and then maybe turn it over to one of the CMOHs for a jurisdictional perspective. We've actually prioritized those workers, and so we wouldn't be amending any further recommendations. Actually, the extended dose interval enables those workers to get vaccinated sooner than they would have, at least with the first dose, using the authorized interval.
Sure, and I'm happy to talk first. Obviously, this is something that we consider very carefully in the provinces, and we are looking at how to protect the most people as quickly as possible. And we have seen, and this is really important, we've seen dramatic decreases in cases in long-term care, and now starting to see the effects of the community immunization in older people as well. So that's really important. We in BC have always had a second stream that we've targeted towards workers, and we've been working on that with the AstraZeneca vaccine, we're being much more flexible and giving you the ability to go out to workplaces more effectively. That has, of course, been suspended in people under age 55. So that has been a little bit of a wrinkle in that. So we are looking at how we can best target people who cannot work from home. And I know my colleagues across the country are having these same conversations and how to do that with the vaccines that we have, recognizing that we are now also protecting a large group of people in the community. So all of the age-based program does have an effect as well on preventing transmission and preventing hospitalizations. So it is a balancing act and it's a challenging one. We have, all of us, been targeting workplaces that have had outbreaks, and I know we've been quite successful out here in getting food processing and farm workers and others immunized in the program so far, and we will be continuing to do that, and we'll be waiting for other vaccines to become available. And one of the things that we are hopeful for and are hearing might come soon is the Johnson & Johnson vaccine, which again gives us more flexibility.
Thank you very much. We'll now move to the next question.
Thank you. Merci. Notre prochaine question est de Philippe Vincent Foisy de Radio-Canada. À vous la parole. Please go ahead.
Oui, bonjour. Peut-être juste Madame Quash, puis s'il y a quelqu'un d'autre qui veut commenter en français là, sur AstraZeneca, j'aimerais vous entendre sur ce que l'Agence européenne a dit aujourd'hui, qu'il y a de fort probablement un lien avec les thromboses. Est-ce que ça peut changer votre stratégie? Est-ce que ça vous inquiète de voir les résultats qui ont été publiés là, par l'Agence européenne des médicaments?
Je ne sais pas si Dr. New veut commencer comme tu l'as.
Oui, je pense qu'il y a une séquence, comme j'avais déjà constaté en anglais. Le régulateur, c'était Santé Canada, est en étroite communication avec les homologues en Europe. Les représentants ont fait même partie des réunions, des téléconférences de l'agence en Europe. Et ils sont au courant avec l'évidence aussi ce que l'agence en Europe peut-être va présenter aujourd'hui. Santé Canada entend encore les autres données probantes de AstraZeneca, le fabricant, et aussi va prendre en considération les données probantes que les Européens ont considérées et va déterminer les prochaines étapes. Et après, je cède la parole à Dr. Quash.
Merci, Dr. New. En fait, ce que Dr. Dix disait tout à l'heure, c'est que le CCNI avait déjà mis le vaccin AstraZeneca sur pause en attendant justement les investigations plus poussées de Santé Canada. L'énoncé de l'Agence européenne des médicaments fait en fait suite à ça. Donc, pour l'instant, en attendant la fin de l'enquête de Santé Canada, nous poursuivons notre pause et par la suite, nous réévaluerons les données qui seront disponibles pour voir si on maintient en fait la recommandation actuelle ou si on la change. Mais pour l'instant, ça ne change rien là, à notre recommandation actuelle. Merci.
Et Vincent, question suivie?
Oui, merci. Sur le délai de 4 mois, à quel point, si on avait tous les vaccins du monde entier, ce ne serait pas une recommandation pour vous? À quel point 4 mois est une nécessité dans la mesure où on a vraiment une grande rareté dans la quantité de vaccins qu'on reçoit? Puis, juste vous entendre en français aussi là, sur les groupes prioritaires.
Oui, bien, en fait, au-delà de la quantité de vaccins disponibles, il y a aussi la capacité à les administrer. Donc, il faut à un certain point décider si le bénéfice est plus grand à vacciner un plus grand nombre de Canadiens rapidement versus en vacciner la moitié moins avec 2 doses. Donc, c'est sûr que en termes de quantité, il a fallu prendre cette décision-là, mais il fallait aussi se positionner quant à l'aspect le plus important, qui dans celui-ci a été de déployer la plus grande quantité de vaccins possible pour avoir une protection même un peu moins optimale individuellement, mais qui donne une protection au niveau populationnel qui est bien plus grande. Et donc, c'est dans ce contexte-là qu'on est arrivé avec un 4 mois en mettant bien en évidence qu'au fur et à mesure que les quantités augmentent, on ne s'attend pas à ce que ce délai-là de 4 mois persiste. On pense qu'éventuellement, un délai beaucoup plus court, autour de 2 mois, va être possible avec les quantités disponibles.
Sur les groupes prioritaires.
Ah, pardon. Pour les groupes prioritaires, donc le CCNI avait déjà énoncé que dans son deuxième groupe, une fois que les personnes plus âgées avaient été vaccinées, il y avait les personnes, les travailleurs essentiels, incluant ceux qui ne pouvaient pas faire du télétravail. Et donc, nous, on en est rendu là, donc nos groupes prioritaires ne changent pas, mais donc je vais peut-être passer la parole à Dr. Russell pour qu'elle puisse expliquer d'un point de vue provincial comment est-ce que ces décisions-là sont prises, parce qu'en bout de ligne, le déploiement des programmes de vaccination sont de juridiction provinciale. Merci.
Oui, juste pour faire le point, comme Dr. Quash a dit, que c'est les provinces qui ont et les territoires qui peuvent faire les décisions comment déployer les vaccins à fur et à mesure qu'on les reçoit. Et c'est vrai que le nombre de doses qu'on a reçues jusqu'à maintenant, c'est tellement petit. C'est pour ça que la priorisation était tellement importante. Ici, au Nouveau-Brunswick, on est unique parce qu'on a des nombres de cas très bas à ce moment-ci, mais quand même, c'est une province avec beaucoup d'endroits ruraux. Alors, c'est important de faire certaine qu'en termes d'équité, que toute la province peut recevoir des doses basées sur les âges, qu'on sait qu'il y a un risque élevé, et aussi les travailleurs de santé et d'autres types de travailleurs qui ont un risque élevé à ce moment-ci. Mais c'est vraiment au niveau de la population en total qu'on fait des décisions comparées à les risques individuels.
Merci, Dr. Russell. Next question.
Thank you. Our next question is from Mackenzie Gray from CTV News. Please go ahead. À vous la parole.
Hi there. My first question is for Dr. Deeks. Dr. Deeks, the European Medicine Agency said today that the blood clot issues with AstraZeneca are very rare, and they continue to say that the benefits outweigh the risk from the shots. During the last press conference, you said that there's substantial uncertainty about providing benefits of AstraZeneca to adults under 55. Given the news from the EU today, is it still your position that there's substantial uncertainty around AstraZeneca?
Yes, thank you very much for that question. I think what we need to do is actually look further at the data now that the Pharmacovigilance Committee of the European regulator has made a statement, and look at it in the Canadian context. We're looking forward to receiving further information from Health Canada. We made the decision out of an abundance of caution while further investigations were ongoing. So we will now look at the new data. They have looked at more cases than were previously looked at. I think it was in March 18th. And we'll see if we need to make any changes in the NACI recommendations for AstraZeneca. Thank you.
Thank you. Follow-up?
My follow-up question is for Dr. Deeks as well. In the writing that NACI put out today, they said that one shot of Pfizer or Moderna seems to be equal to 2 doses of AstraZeneca. Considering the issues and the hesitancy that we've seen with AstraZeneca so far, and the fact that it's only available for people above 55, and many provinces are now starting to offer AstraZeneca and Moderna and Pfizer for people under 55, are you concerned that Canadians are not going to take AstraZeneca, considering both the restrictions and some of the hesitancy around it?
So we are very fortunate in Canada that we have multiple different vaccines. Currently, we have 3 with Janssen, as Dr. Henry said, being forthcoming. You know, I think it's premature to know how this announcement will actually impact confidence. What we've tried to be doing at NACI is actually being quite transparent about the evolution of the data so that Canadians will have confidence that we are communicating what we know about safety when we know it. And that is why that we put a pause on the program. You know, we have been criticized for changing recommendations, and you know, the vaccine rollout has actually been quite confusing in terms of data becoming available as vaccines are being used in the real world settings. Sometimes changing recommendations cause distrust or hesitancy. But what we're trying to do is to continue to communicate the rationale behind our decisions so that Canadians can feel confident in the vaccines that they're receiving. And that includes AstraZeneca, but also the mRNA vaccines. Thanks.
Thank you very much. We'll now move to the next question. Opérateur, prochaine question.
Thank you. Merci. La prochaine question est de Marie Vastel du Devoir. À vous la parole. Please go ahead.
Oui, bonjour. Je veux juste noter que le son est très, très mauvais. Donc, peut-être pour la prochaine téléconférence, je ne sais pas c'est quoi la solution, mais peut-être essayer de voir s'il y a moyen de l'améliorer parce que c'est dur de comprendre là, certains des médecins qui parlent. Mais je pense que ma question est pour la docteure Quash, je crois. Il y a des études internationales qui indiquent que les résidents en centre de soins de longue durée, donc des gens très âgés, souvent affectés par des comorbidités, bénéficient d'une moins bonne protection avec la première dose de vaccin. Je me demandais, est-ce que vous avez pris connaissance de ces études-là à l'international? Est-ce que vous endossez ces conclusions-là ou ces doutes-là, je ne sais pas comment vous voulez le qualifier, et comme ces gens-là, là, les résidents de centres de soins de longue durée sont peu nombreux, donc quand même rapides à vacciner, est-ce qu'il faudrait leur donner une deuxième dose le plus vite possible, accélérer la deuxième dose pour ces gens-là qui sont pas suffisamment protégés avec une seule?
Oui, merci Mme Vastel pour votre question. J'espère que vous m'entendez bien. Là, si tel n'est pas le cas, juste me le dire. Mais... OK, ça marche. Mais donc, oui, on est au courant de ces données-là. Je pense que ce qu'il faut préciser, c'est que les données, ces études-là ne regardent pas la protection en termes d'efficacité réelle, mais regardent la réponse en termes d'anticorps. Donc, ce qu'on voit, c'est qu'effectivement, les personnes plus âgées, qu'elles soient en CHSLD ou juste plus âgées, ont une réponse en anticorps moins élevée qu'une personne plus jeune en bonne santé. Ça, c'est clair, on le voit. Par contre, là où il y a un élément qui est un peu qui est plus difficile à saisir, c'est qu'on n'a pas de corrélat de protection présentement. Ce que ça veut dire, c'est que c'est pas à partir d'un certain seuil qu'on sait qu'on est protégé. Certaines personnes auront des anticorps un peu plus élevés, vont faire la maladie quand même. D'autres auront des anticorps très bas et seront protégés. Et donc, c'est pas que la quantité d'anticorps qui compte. Il y a la sorte d'anticorps et il y a l'immunité cellulaire aussi, qui est l'autre pendant de la protection conférée par un vaccin. Ceci étant dit, quand on regarde les données d'efficacité de terrain, donc effectiveness en CHSLD, que ce soit en Colombie-Britannique, en Grande-Bretagne ou au Québec, l'efficacité vaccinale pour les personnes en CHSLD demeure très bonne, donc autour de 70 à 80% contre les infections graves et les hospitalisations et décès. Et c'est donc en prenant tout ça ensemble où on s'est dit, bon, oui, c'est sûr qu'il y a une possibilité de donner une deuxième dose plus rapprochée à certains groupes, mais que d'un point de vue d'équité, on essaie quand même d'étaler, je vous dirais, la protection au plus grand nombre de personnes possible parce qu'on voit présentement que ce sont les plus jeunes qui se retrouvent avec des complications et des décès suite à la COVID, alors que des éclosions en CHSLD, on en a à peu près plus. Et quand on en a, les conséquences sont très peu graves, c'est-à-dire qu'ils ont un rhume, ont quelques symptômes, parfois rien du tout, mais que les transferts en centre hospitalier ne semblent plus survenir. Une fois ceci dit, au niveau fédéral, je vous dirais que la fin de la réponse revient aux provinces puisque la santé est de juridiction provinciale et donc chaque province peut moduler à sa façon en fonction de la quantité de vaccins puis du programme qui est en place, une province pourrait décider effectivement de raccourcir l'intervalle entre les doses pour les personnes plus âgées. Mais je pense que quand on regarde les données d'efficacité de terrain, jusqu'à maintenant, elles sont rassurantes et on arrive là, aux 3-4 mois de délai et ces personnes-là en CHSLD vont commencer à recevoir leur deuxième dose sous peu. Merci.
Mm-hmm. Oui, donc j'en comprends que pour ce qui est de votre comité, en tout cas, on ne recommande pas nécessairement de changer la façon de faire compte tenu de tout ce que vous m'avez exposé. Donc, si je me trompe, dites-le moi, mais je pense que c'est ça. Et juste sur AstraZeneca, vous et la Dr. Dix avez répété que vous allez évaluer les nouvelles données et les études que vont en faire Santé Canada, mais avez-vous un échéancier approximatif, à savoir quand est-ce que vous allez décider si vous modifiez vos recommandations sur AstraZeneca ou pas? Est-ce qu'on parle de semaines, de mois? Pouvez-vous nous donner juste une idée de quand ce verdict-là pourrait venir?
Bien, écoutez, ça dépend déjà de la rapidité à laquelle le Santé Canada nous transmettra le rapport. Donc, on s'attend à l'avoir d'ici 1 à 2 semaines pour que le comité se penche ensuite sur ces recommandations-là. L'idée, c'est de ne pas faire traîner le plaisir, mais vraiment d'être capable d'évaluer les données de façon efficiente pour pouvoir faire la recommandation. Donc, j'ai l'impression que d'ici 2-3 semaines, maximum 1 mois, on devrait avoir nos recommandations, mais je vous dirais que l'élément... l'entonnoir ici, c'est à savoir quand est-ce que Santé Canada nous transmettra leurs données. Et comme je vous dis, on a l'impression que ça ne devrait pas tarder, mais comme on ne les a pas encore, je ne peux pas vous le dire hors de tout doute raisonnable.
Merci.
Merci beaucoup. Operator, next question.
Thank you. Our next question is from Tanda McCharles from the Toronto Star. Please go ahead. À vous la parole.
Hi, thanks for taking my question. I just want to echo what Marie said. The sound is pretty rough trying to understand. So I wonder if you could speak to a couple of other aspects about the vaccines that people are also wondering about. Where are you at? And perhaps this is for Dr. Quash or maybe Dr. Henry. Where are you at in considering the idea of mixing and matching different vaccines for the first and second dose? In other words, if we get more of one than another, and it's possible to give people a second dose earlier, do you recommend at this stage, or do you think can you foresee recommending the mixing and matching strategy?
Yeah, so thank you for your question. It's Carolyn Quash. So at this point in time, we are not recommending a mix and match schedule. We are awaiting, however, data from the UK where the AstraZeneca and Pfizer vaccine are being studied as a mixed schedule. We are expecting data in the month of June. In the meantime, what NACI has recommended is that if you start with an mRNA vaccine, and for some reason, either you don't remember which one it was or you're running out of that vaccine, we can use the same platform vaccine, but trying to stay within with the same vaccine. But at this point in time, to do AstraZeneca and then switching to mRNA is in the works, but we haven't made that recommendation yet. Thank you.
Yeah. And I can just add to that. It's Bonnie Henry here. Just that this is obviously something we're watching very carefully, and we have some time to understand. And the studies that are going on in the UK are really helpful, and we're piggybacking on some of them here, looking at the dose interval and which is the optimal timing for the different vaccines. So this is something that we're paying a lot of attention to. We do have, as you know, a lot of mRNA vaccines coming in the next few months. So the possibilities of boosting and understanding how we can modify the vaccines to address variants if need be is also something that we're watching very carefully.
We continue to hear people, and this is confusing to a lot of Canadians, to hear people like the Chief Science Advisor to the government, Mona Niemer, telling us that this idea of spacing out these doses is a giant population-level experiment. Other credible voices in the medical community have also endorsed that. So I wonder if you could, in the first instance, respond directly to that, and if you are looking at some specific evidence to endorse your own dosing recommendation today, Specifically, what piece of evidence was most persuasive to you?
I guess I can start with that. You know, there's a science of epidemiology and public health practice that looks at both individual level protection and population level protection, and that is the work that we do. And the experts that you see in this panel all understand that there are balancing and trade-offs, and that you can best protect people by providing them with community protection as well as individual protection. We've done a lot of work, and there's a lot of years of expertise around immunizations and how immunizations work. And I think that is what helps me understand the important measures that we're taking and how to best use the vaccines that we have. I do want to say, though, when all of these clinical trials were done, the clinical trials were established, the protocols were all thought up at a time where we didn't know what vaccines were actually going to work and how well they were going to work and who they were going to work in. They were designed to give us that information as quickly as possible. And we know from vaccinology, from the way our body's immune system works, that it takes time between doses. So your body's cell-mediated immunity, the part of your immunity you're less able to measure, for that to develop the longer-lasting, more durable protection. And we've seen that with many other prime and boosting vaccine schedules. So the fact that the minimum time possible was used, which was 2 weeks and 4 weeks in the clinical trials, really only reflects trying to get as much information as quickly as possible about whether these vaccines were going to work at all and who they would work in. And I think, to me, the things that are really miraculous about these vaccines are that they work well in older people. And that is something that we have not seen in many other immunization programs. We think of influenza, for example, where we know it doesn't work as well, the vaccines that we have available right now. So that is one of the things that really struck me as being important. We also learned that we have really good protection, even in elderly people, that lasts for a long period of time. And this goes to the other important thing that we have, that we do in public health, which is monitoring every single dose of vaccine and following people and linking that information to see if people get infected. And we do that through here in BC, through the BC Centre for Disease Control, but we have teams in Quebec and across the country that are doing this type of work to help us understand if the vaccines are working in the real world. So the clinical trials are what we call efficacy. They give us this idea in the perfect sense with a well-controlled study, with all the people who have underlying conditions screened out. Do they work? And then effectiveness is how well do they actually work in the real world? And that's what we're learning. We're learning from the UK, we're learning from other countries that have gone before us, and we're learning from the day-to-day monitoring of every single dose of vaccine in Canada. So that real-world effectiveness, when we started to see the dramatic drop-off in infections in long-term care, and that elderly people in long-term care were protected really well after their first dose, that was the most important thing that I saw, and we're continuing to monitor that and see that long-lasting protection after the single dose continues. We were just looking at some of that data. I know it's been shared with NACI and in some of the deliberations around this. So these are the types of decisions that we need to make on a daily basis, getting through this crisis. So we also look at modeling. We look at the fact that the high protection, is 80% with a single dose. So getting that up to maybe 90% in an individual, as opposed to having two people with 80% protection, is one of the sort of simplest ways of thinking about it. But on a population basis, and we see that in the UK, as soon as you get a level of immunization in the population your transmission rates go down dramatically. So right now, we're seeing the protection from severe illness in older people in our community. And as we get more and more vaccine out there, we expect to see what they've seen in places like the UK, where infections drop off again. So that is the sole goal of us trying to protect the population. And when we see decreasing rates of transmission, it protects us as an individual as well. So the best protection we have for everybody is to get as many people protected as quickly as possible.
Thank you.
Thank you. Operator, next question.
Thank you. Our next question is from Mike Lecoteur from Global News. Please go ahead. À vous la parole.
Good morning. Thank you for taking our questions. I'm not sure who to address this to, but correct me if I'm wrong. Is Canada still the only country using the 4-month delay in between vaccines? And with the government boasting about the flood of vaccines coming into the country, why aren't we looking at moving into a shorter spacing between the doses?
So thanks for your question. I can start. A number of countries are using extended intervals. A number are using 3-month intervals. I think Canada might be the only one using a 4-month interval. But as we've emphasized previously, what the recommendation is delay between the first and second dose of up to 4 months. What we are expecting to see as the provinces and territories efficiently roll out the programs is that period of time actually can decrease as more and more people are getting vaccinated. And I know a number of jurisdictions are already under discussion about decreasing the interval based on where they are in the delivery of the program. Thanks.
Can I add to that just one little thing, in that we know from many other vaccine programs that actually a longer interval gives you longer lasting protection. So we still don't have the perfect answer yet. It will be, hopefully we'll be able to get people the second doses sooner than 4 months, but it may turn out that the optimal dosing is actually 5 months or 6 months. 6 months is being one that we've seen with others. Because we're thinking now the pandemic hopefully will be over once we start getting most people immunized, but COVID will still be with us, and we need to understand how long the protection will last for next respiratory season. And we don't have those answers yet. This is all science in action. We're learning as we go. So it may turn out that the optimal dosing that we'll discover over the next 6 months, next year or 2 years, is a bit longer than 4 months. But right now, we know that with the modeling, the doses that we have available, and the epidemic we're seeing in our communities, that we may need to extend out to 4 months for some people.
Thank you. A follow-up?
Yeah, so just as a follow-up, earlier in the press conference, you said that the interval should be shorter. So I wanted to know how much shorter, and also if most adults are expected to get their first dose by mid-June, when can people reasonably expect their second dose by?
So in terms of the interval being shorter, what I meant by that, if that was me that you're referring to who said that, was that the first priority is actually getting first dose into arms. After first doses are in arms, then second doses can start. So depending on where provinces and territories are in their vaccine rollout, they will be delivering second doses prior to the 4-month interval. There is no kind of magic time point at 4 months or 3 months. As Dr. Henry mentioned, oftentimes we have longer delays, and we have a more primed immune system, so a higher boost at the 6-month period. But right now, the effort and energy is getting first dose in as many arms as quickly as possible to protect as many people as possible, especially given the ongoing transmission in a number of jurisdictions.
Thank you very much. We'll move to the next question. Question.
Thank you. Merci. Our next question is from Cormac McSweeney from City News. Please go ahead. À vous la parole.
Sorry, I was on mute there. Just wanted to ask about some of the criticisms a month ago when you first introduced this recommendation of 4 months. A number of immunologists and researchers came out and said that this could be a risky gamble. They were concerned that a 4-month gap could, just some of the issues that they had, could potentially create a new variant because it allows more time without full protection for the virus to mutate. Also, the option that possibly there could be needed for booster shots later in the year if there isn't proper protection or following the proper guidelines from these pharmaceutical companies. In your research and the real-world evidence that you looked at, did it specifically address the issue of variants and booster shots? What did you find, and what do you believe the risks are of those two issues?
Yeah, I may take this one. I think if you've looked at the paper that was just published in Nature last week, where a virologist with a mathematical modeler have looked at the risk of creating variants in people who are vaccinated with 1 dose and spreading that protection in more people in the population, the risk is actually not seen. If it's there, it's less than the risk of not vaccinating more people with 1 dose. What we know in terms of transmission and variants is that the more the virus transmits itself, the more it replicates, the more likely it is to create a variant of concern eventually. And so the goal here is really to give that protection to as many people as possible. I think that, the questions that were raised were good questions. They were theoretical questions, but it's not something that has been seen in the virology world. Even if you were to look at influenza, for which we vaccinate every year with a protection, even after the dose of 40 to 50%, we're far from the 80% we're talking about here. We're not seeing emergence of variants in the population that is vaccinated. Variants come because they emerge naturally, because we don't know why and how, but those viruses have a tendency to make mistakes as they copy. And if that mistake is actually beneficial from their survival perspective, then they'll keep that error. But it's not because you're vaccinated that you're at increased risk of seeing that error. Now, that is one item. Your other question was about need for boosters. If we wait too long for to give our second dose, I think Dr. Henry has spoken to this already. What we know from immunology and vaccinology is that within even a year time, you have memory cells that are going to be able to produce antibodies again. Even 10 years after a hepatitis B series, your memory cells are still able to produce antibodies. So it might take a bit longer before they kick in to produce, but eventually they will produce. And so I think we need to take into account all the knowledge that we have from prior our prior knowledge from immunology, and not just think that with this virus, everything is going to be different, although some things have been different, but not everything. So it's really based on those prior knowledge that we made our recommendations. Thank you.
Thank you. Just as a follow-up, I'm just seeking some clarity on something my colleague Mike had asked a little bit earlier. But I believe I heard in French, and I can't remember which expert it was that mentioned it, that you were looking at potentially moving it when vaccine supplies are plentiful, that the gap between the doses could move from 4 months to 2 months. And then in English, you were less clear about that. So if you could just clarify, are you expecting to move it down to 2 months at some point, or is that not accurate?
So it was me in French, and I'll say it again in English. So what we're expecting in terms of supplies is that as as supplies roll in and we have enough, that interval will decrease. Our estimate is that eventually we will be able to go, close to 2.5 months or 2 months interval between doses, but that really will depend on how many doses come in. But in terms of what is coming, it's what we're expecting to see happen. But again, that is under the jurisdictions of the provinces and territories. And I think you'd have to ask them, how they see this rollout play out. But, in terms of supplies expected, it will eventually be possible to shorten that interval. Thank you.
Thank you. As time is flying, we have time for one last question. One more question. Operator, over to you.
Thank you. Our last question is from Jamie Pachaguskum from APTN. Please go ahead. À vous la parole.
Hi. Yeah, sorry, I was on mute also. Back to my colleague's question about boosters. Today, you guys mentioned that the first dose is effective up to 6 months and the second dose even longer. Do we know how long that is for the second dose and when we will require boosters?
So that's a good question. Moderna just issued a press release to say that 6 months after their second dose, they were still able to find antibodies and even neutralizing antibodies. So there seems to be a protection that lasts at least 6 months' time. I think that, as with everything in this pandemic, we learn as we go because we have no choice. The first vaccines were really rolled out in December, and we're, barely 4 months later. From the clinical trials, the only thing we can do is, take those people who were vaccinated at first and see if we're still able to detect antibodies in them. Remembering, as what I said before, is that antibodies is not the end all and be all. You also have cell-mediated immunity. You have, some neutralizing antibodies that might not be detectable but are still there. So with a big caveat, there seems to still be protection, well, at least antibodies 6 months after the second dose for Moderna. But that's about all we have for now. And so it's the ongoing surveillance of the vaccine effectiveness in real world as exposure continues that will allow us to know how long we're protected against COVID. Thank you.
The only thing to add to that is that this is not unusual for other vaccine programs. Often when we implement a vaccine program, if we think of HPV vaccine, for example, we didn't know how long the vaccine was going to protect against. So the clinic has been ahead of where the vaccine program rollout is. And we continue to monitor those clinical trials as well as real world effectiveness and then adjust recommendations accordingly. For HPV, we know now that you, at this point in time, had to do the reverse. Originally, we thought you only needed 1 dose of MMR vaccine for protection against mumps. Now, you need 2 or sometimes even 3, depending on the situation. So although we are learning in COVID, it's not unusual for us in the immunization world to adjust programs as the vaccines become more in use in populations because we learn more as we go. Thanks.
Thank you, Doctor. Follow-up?
Yeah. This has to do with the younger age groups. Now, it's said that the new variants are affecting younger age groups more severely. With people in long-term care homes, effectiveness appears to be good, along with the elderly. Would it make sense to prioritize younger ages, maybe even 16 plus, because there are spreads in schools?
Jennifer, you want to take this?
Well, again, we do go by NACI recommendations at the province and territorial level based on our own epidemiology. So I know that across the country and different provinces, they do have different ways of approaching that, including teachers getting vaccinated. Here in our province, we're looking at getting all of our teachers vaccinated very shortly. So again, it is a jurisdiction by jurisdiction decision, again, based on the broad NACI recommendations.
Thank you very much. That will be all for today's technical briefing. That will conclude today's technical briefing. Merci beaucoup et passez une excellente journée. Au revoir.
Thank you.